Hi, everyone. Good evening, good afternoon, wherever you are in the world. I'm Dr. Jen Johnson of the IVAPM board, and I'm so excited to be here with you all today and to have Dr. Giliola Spattini from Italy talking to us today about the role of ultrasound in detecting pain in our patients. And I really appreciate her talking about this with us and teaching us a little bit of how to use some diagnostics. Her expertise is in diagnostic imaging and pain management, where she went to Parma University and then did a residency program in diagnostic imaging. And she's a sports medicine expert and works with them using ultrasound on musculoskeletal disease and diagnosis as well. It's wonderful to have her. I don't think I need to blather on about this. We'll have time hopefully in the end for some questions and answers, and I appreciate all of you joining us today. And thank you, Dr. Spattini.
Thank you for the kind introduction. It's a real pleasure for me to be here, sharing with you what I'm learning is a work in progress. I've been involved in musculoskeletal ultrasound for the last 15 years, and actually my major patients are two kinds of patients: sportive that are in pain or that they need to avoid pain, or patient, young or old, that have a chronic condition that usually lead to pain. And I'm going to show you how we can use ultrasound and all other diagnostic imaging modality to try to understand what we need to treat. Ultrasound is finally worldwide known to be particularly helpful in musculoskeletal disease, at least in the shoulder. I must say that in the last 4 years, I've been invited at the European Congress of Orthopedic Surgeons to talk about ultrasound. And now even the orthopedic recognize that is very important for diagnosis muscle tendon disease. But what I found really helpful is in this kind of patient. This is Mia, Labrador. She's only 2 years old. She started to be lame when she was 5 months of age. At the orthopedic examination, she was positive for pain in the right elbow. And at the time when she was only 5, radiographs were obtained. Unfortunately, only of the right side. Usually it's always better to have both sides. What was evident is that there is an increased sclerosis. So this part of the bone is whiter, and the more thickened and white is the bone, more pressure is carried. And in a very young patient, to have a sclerosis of the ulnar notch is really worrisome, because it means there is too much pressure on the medial coronoid process. And this is radiographic sign that tell us that this dog has a really great chance, high chance to develop fragmented coronoid process. Usually, if you detect this sign really early, you can try to make some surgical correction. In this patient, radiographs were quite suggestive of a problem, but the owner was not sure that she wanted to try surgery in an apparently healthy dog. So she waited a little bit. At 6 months of age, this dog went for CT, and in the elbow CT is fantastic because you show much better problem. And at 6 months of age, this dog has already developed bilateral fragmentation of the coronoid process. This is the right side where you can see this big fragment. This is the medial margin of the medial coronoid process. And then there is the left side where quite similar, a little bit less severe, but quite similar problem with a large piece of bone was present. We know that this patient will develop bilateral severe arthrosis. She is 6 months of age. So it's your job, start to treat this patient and try to avoid discomfort. And we know that we need to manage this patient for all her life. This is not when I saw this patient, because we know that she is having arthrosis and we know that we need to treat her for her life, hopefully using as less as possible pharmaceutical. She came to me at 2 years of age because she stopped responding to non-steroid anti-inflammatory drug. Before was quite easy with physiotherapy, control exercise, minimal pain management, pharmaceutical. There was not a big problem. She was doing fine. But now and recently, after a minor exercise, she had a severe right front lameness, and usually was a 1st degree lameness. Now she's a 3rd degree. She doesn't want to use this leg, and she's not responding to any treatment. These are my patients. This is where ultrasound can help us to define what is going on. We can use ultrasound only after a complete physical examination. That is always the most accurate diagnostic modality that we can have, and then radiology. Otherwise, this will be malpractice. What could happen when ultrasound became so popular is that general practitioner, they have a lame dog. They know that usually with ultrasound, you don't need sedation. Most of the time, the dog is standing, and we saw the patient when it's not in acute phase. So they are not really discomfort. And they prefer to send ultrasound before radiology, so they don't need to sedate the patient. But this is not correct. Otherwise, you could end performing a shoulder ultrasound in a patient that has a humeral tumor. And ultrasound is extremely good in detecting soft tissue, so tendon and muscle, but it's not really good in detecting bone, especially if the surface of the bone is intact. We will not see any lesion in the bone. So be sure that before you plan your ultrasound, you have a complete physical examination to localize the pain and what is the problem. And you also have radiograph to avoid evident pathology or to avoid to miss the most important aspect. Not surprisingly, the dog at 2 years of age with bilateral fragmentation of the chronoid process has a quite advanced and severe dysplasia. But at physical examination, the shoulder and the right carpus, so the left shoulder and the right carpus were also painful. And the physiotherapist that sent me this patient, she was a little bit confused why this dog has elbow disease and chronic problem, and now is so painful in the shoulder, left shoulder and right carpus, and why is not responding to treatment. When she arrived to me, we know that she has severe bilateral elbow dysplasia. In the last time was not really responding to treatment. And on physical examination, the left shoulder and the right carpus were painful. And basically had ultrasound request to stage 4 pain. What can we detect with ultrasound? First of all, I started to perform ultrasound of the musculoskeletal system 15 years ago. I went back to Italy after staying away all around the world for 11 years. And I live quite close to one of the biggest physiotherapy centers that we have. And my colleague asked me, can you do a shoulder ultrasound for me? Well, I'm used to horse. It shouldn't be too much different for dog. Well, at the beginning, it was a little bit a nightmare because you don't have book, you don't have references, so it was quite difficult. But I got really involved and I started to do research on this topic. I did a lot of anatomical study to be able to use this methodology. What you see here is my power, that is a combination of radiology and the muscle. I use as an anatomical resource IMAIOS, that is fantastic. And these are my hobby, that is cutting and taking out muscle and structure to be able to recognize them. So if you're looking at a radiograph, you should also consider the important muscle that we should consider when we are considering the shoulder. There will be infraspinatus, is the green one, the supraspinatus, bicep tendon, and the triceps. These are probably the 4 most important muscle in the shoulder and the one that most of the time creating pain. These are static image. Infraspinatus, I call the infraspinatus the seagull muscle because the tendon seems a seagull. I call the supraspinatus the king. Consider that supraspinatus alone, when the dog is running, is able to carry 4.6 times the weight of the dog. If the dog is 20 kilo, the supraspinatus is carrying probably around 90 kilograms. And this is the reason why it's different from all the other muscle, because the end of this muscle is fibrocartilaginous, is nearly a bone. And this is why this muscle has a very low, and especially the tendon, pain receptor. You can have a lot of damage to this tendon. It's quite difficult to be extremely painful. The problem is, and this is how you scan your patient, starting from the infraspinatus. This is the spine of the scapula. You see that the bone for us is black. And this is why we are so insensitive in detecting bone disease. But then we can see so nicely supraspinatus, brachiocephalicus, trapezius, and this will be deltoideus and tricep muscle. The good news is that every muscle is different. And what really ultrasound is extremely good at is checking how the tendon and the muscle move between each other. This is the insertion, this is the scapula, the supracranoid process. This is the cartilage of the humor, this is humor. This is the region of the bicep tendon. And this is a aponeurotic portion of the supraspinatus tendon. And you can see that the bicep and the supraspinatus tendon run really close. They are in an opposite direction and they need to slide up and down. If the supraspinatus get a lot of injury, that is quite normal in an active patient, it will not be a big problem because pain receptors are very minimal. Usually you have little hemorrhage inside the tendon that will became a mineralization. We have commonly on radiograph area of mineralization in the area of the supraspinatus muscle, but most of the time we don't know what it means, if they are normal or abnormal. If they are inside this portion of the tendon, they are of no clinical significance. If they are on the surface of the tendon, considering how close the tendon is to the bicep tendon and the joint capsule that usually is so thin that you don't see that, you can imagine if you have severe enlargement or mineralization on the surface of the supraspinatus tendon, that then the dog became painful because the bicep tendon has so many pain receptors that every time the supraspinatus push a little bit, so get enlarged and start to friction of the bicep tendon, then you'll have acute lameness and a lot of pain. But in this patient, we're quite nice. This is the elbow, and the bone, what is normal, should be a very smooth and regular surface. In this patient, we have the fragment, we have some fluid, we have chronic changes at the attachment of the tendon, of the flexor, of the carpus. But what we are looking at are hyperechoic region. Hyperechoic, that means white, with really ill-defined margin, means acute inflammation. What I usually do, I scan my patient. If I scan a shoulder, I always include the elbow. A reason why, for example, the bicep tendon start in the shoulder but end in the radius and ulna. And if I'm scanning a muscle, I need to start scanning the beginning and the end. So this is a chronic elbow with severe arthrosis, but I don't have any acute condition. This elbow at the moment is not painful. What is very nice about ultrasound is that if you found a hyperechoic region, then you touch that region and you see if the dog is reacting or not. So you can actually say when a region is very important or of no clinical significance. This is the left elbow. Again, is not perfect because we have a large piece of bone. We have chronic changes. You see how we cannot really differentiate very nicely the insertional tendon of the flexor of the carpi. I should see 3 different tendons in this area. It's very common when you have a chronic arthrosis in a patient. The patient change way of walking, and for that reason, you have chronic tendonitis. And chronic epicondylitis is one of the most common cause of pain in patients with arthrosis that stop to respond nicely to painkiller. Why tendon don't respond to painkiller? Because they have only 1/10 of the blood supply of all other tissue. They don't receive a lot of blood. There are fibers close with collagen, and they don't need oxygen. And because they have so little blood supply, you can't really use systemic drug or intervention. Most of the time, you need to use local management for tendon problem. And again, a lot of changes, but I don't see site of inflammation. We are now down to the carpus. This is the sternocarpi radiali, that is one of the most important tendon in the dorsal face of the patient. I'm using a 18 megahertz probe that is a quite high resolution probe. This is the bone. Again, have a surface, but I cannot really see anything about the bone. I have my tendon that proximally is oval, and then he divided into components, a small one and a large one. And this is the side that shows no pain, and this is the other side. You see there is a lot of effusion surrounding the tendon. And I say a lot of effusion, but this is most likely 1 or 2 millimeters. This is the tendon in a longitudinal way. This is the radius. This is the first row of the carpus. And I do see there is effusion surrounding the tendon sheet, and is also effusion in the carpal joint. Why a dog that has a chronic problem in the elbow could develop a carpal disease or a shoulder pain? Well, he has the most severe osteoarthrosis in the right elbow. And our patient, when they have chronic pain, they change the way they put weight. So he's probably putting more weight on the left shoulder. And we found pain in the left shoulder, even if we didn't find any radiographic and ultrasonographic changes. I will tell you later why. And then we have pain in the right carpus, and we'll start to see changes because the dog, to avoid to put too much weight on the right elbow, is putting a lot of weight in the right carpus. And most of the time, due to the pressure overload, you will start to have carpal disease, and we can also have tendonitis. This is the sound side, that is the left carpus, and we do see the big extensor lateralis. The ulnaris lateralis tendon is so big that sometimes nearly seems a bone, absolutely normal in the left side. And this is the right side. The same tendon, a little bit more proximal. And you see that the tendon is surrounded by a really thickened synovia that is creating a compartmentalization syndrome. The fluid in the synovia is compressing really badly the tendon. This is one of the most painful conditions that you have. And the only way to relieve pain is decrease the fluid inside the synovia. But again, we are dealing with millimetric change, and most likely you will be able to palpate this condition, but you really need to look for it, or sometimes our fingers are not sensible enough. We can detect that it's painful in this area, but we don't know what is going on. And this is when really ultrasound can help us a lot. And we are staging and looking for problem. So we found out that the problem this patient at the moment was acute tendonitis of the carpus radialis and the ulnaris lateralis on the right carpus, and probably he had an overuse of the left shoulder. He went for physiotherapy. They did a local pain management. If there are some physiotherapists between you, you are better than me and you know what you can do to release tendon pain. He stopped the non-steroid treatment because the pain management got really, really better. And now she is much more active. We know that most of the time, every couple of years, every 1 or 2 years, we need to recheck this patient to see what is happening. And it's a quite hard job for the physiotherapist try to get a good balance between avoiding too much pain in the diseased joint and avoid the overload of pain in the other joint. But this is just a way to use ultrasound to find where the pain is and which kind of pain is, to be able to be more focused on the treatment. And it was all about Mia. My next patient is a greyhound. I have a soft spot for greyhound. I have a whippet at the moment. I had a lot of greyhound. And this lovely dog had a little accident. You see this other greyhound, basically, she was exiting the door and the greyhound made her jump on the door. So she had a trauma in this metal door. And since then, this happened 3 days ago. And she's 3rd-degree lameness. You see how much pain is this dog. She's really only minimally responding to non-steroid anti-inflammatory drugs and painkiller. And the way she's walking, the referring vet is worried that could be some neurological damage because it's really, really showing a lot of problem walking. We know that greyhound can be a little bit difficult to visit because you get close and they start to scream because I'm scared of pain. When she came for the ultrasound, this was her condition after 3 days of painkiller and anti-inflammatory drug. She was crying every time you're trying to touch her. Could be a nerve problem. It was not possible to localize the pain. It could be that MRI, especially if it's a nerve problem, will be much more effective than ultrasound to find a neurological condition, but the owner preferred to start with ultrasound because you need sedation and because the queue for MRI was a little bit longer. We did perform radiology, and you just need a little bit of pain management and light sedation for that. And there was not a lot of changes, some mineralization in the area of the supraspinatus that we know that is very common. We don't know by radiograph if this is relevant or not in our pain management patient. And this is our seagull muscle. This is the infraspinatus. The good news is that every single muscle is different. After a while, you recognize them by name. They are very nice. I hope my muscles are like that, but I strongly doubt it. This is the deltoideus. This is the tricep muscle. I have a fantastic probe where you put the probe and you have the name of the muscle. No, but I wish. However, it is very quite simple after a while that you perform that, and this was absolutely normal. This is the longitudinal way, the reconstruction of the muscle, how it should be. You have a center portion that is quite hyperechoic with thin fiber, that this is the tendon, and then the muscle itself is black, so hyperechoic, with fine line, that is the connective tissue that keep the muscle all together, and this is what is normal. This is the supraspinatus, so we are going to the purple muscle. Is a little bit different because the tendon is oblique. This is one part and the second part. But again, you see that there is quite thick fiber component in this muscle. And this is what is normal. Let's see the disease side. This is what is normal. We have oblique tendon of the supraspinatus. And this is the other side that is affected. You see there is a hyperechoic area, quite large, with ill-defined margin. You cannot really see anything inside this white blob, this hyperechoic area, because there is a scattering artifact. Scattering artifact is extremely sensible and is stable for acute inflammation. If you look at the contour on the bone, there is a minimal step. So probably this is a chip fracture of the spine of the scapula. This is probably the contusive pain. So when the dog stepped and was pushed towards the door, probably this is the early phase of the fracture and the hematoma surrounding this portion. And if you have a scattering artifact, you are 100% sure that you have an acute inflammation. We can use other devices like Doppler. Doppler tells us how much blood is present in this lesion. We see there is increased blood supply that with inflammation and remodeling of hematoma is quite normal. And we know that this is the problem. How we do know that? Finger lesion. Yes. So we check how relevant is the lesion, and we can also inject a painkiller or anesthetic exactly in the area of the lesion to help the patient to get better. Or we can apply local supply to try to make the dog better, because hematoma is extremely painful. And this is how, and when ultrasound is so sensitive, scattering artifact is quite a mystery because we don't know why it happened. We only know that it's very, very associated with inflammation. There have been studies in human where with ultrasound, you saw scattering artifact in the peritoneum. They opened the patient, they didn't find peritonitis, but they take out sample based on ultrasound, and on histology, there was peritonitis. So this artifact is more sensible than the eyes looking directly at the tissue. if we do compare the two sides, it's quite clear where the problem is and how should be a normal muscle and how is a damaged muscle. And if we have scattering artifact, we know there is an acute injury. The problem is how we should classify the damage in the muscle to be able to talk a universal language. There is a lot of confusion in human and even more in veterinary world about muscle lesion. We were quite lucky because in 2013 came out a Munich consensus statement and muscle disease is human, and not all the classification is good for us because we cannot ask the patient if in the morning is more affected than in the afternoon, and we cannot ask the patient if has more pain during exercise or not. But I think it's very good that point out which kind of muscle disease we can have. We have direct muscle injury, that is extrinsic trauma. So trauma from outside, contusion, and chin. My patient has a contusion and you can see how is on ultrasound. And if you shade the dog most of the time, if it's not so deep, you can see the hematoma and the bruise. And most of the time you don't need diagnostic imaging. In this case, was not evident on the surface. Or you have laceration like a bite wound. You don't do diagnostic imaging in a bite wound because you saw directly the wound. These one are the easy one. But we also have indirect muscle injury, and these are the ones that are very difficult to diagnose and to spot because they are functional disorder and could be overextension related. Typical example, agility dog that is training too much and he has not enough time to recover. Or like our patient that has a chronic arthrosis in the elbow and is using too much other muscle. In this case, I think the left shoulder of our previous patient was painful because was using too much of her muscle. And basically, they are overused and they tend to get area of really high concentration of acid that end in trigger point. Trigger point, I'm sure you know much better than me what they are. There have been a big discussion in 2015 if they do exist, if they don't exist. They figure out in human, they do exist, and there are focal accumulation of really high concentration of acid. And if you put a needle and you measure the pH in the trigger point is extremely low. In some paper, they say that a trigger point is like a 2 of pH. Acid is 5. You could consider how is 2. And it's very difficult by ultrasound to be able to find changes in overextension related muscle. We do see some changes, especially in the fascia. The fascia is a fantastic layer of collagen that keep all the muscle together and make us move our body. If I ask you, what is the origin of movement? Is the bone that creates movement? No. Is the muscle? Well, the muscle contract and release. But a single muscle is not able to create movement. Tendon is fantastic because tendon is able to keep the energy, but a tendon alone is not able to make a movement. Fascia put together 56 muscles and allow me to move my elbow and my arm. So basically, when we have overuse disorder, we tend to see changes in the fascia that get thickened. And ultrasound together with MRI are the only two modalities that allowed us to see fascia without cutting and opening the patient. Or we can have neurological disorder. Again, if I have a nerve compression, the muscle will suffer. We tend to see more changes with neurological disorder in the muscle compared to overextension or over fatigue, but most of the time are non-specific. So if you have a normal ultrasound in a painful patient, consider that a fatigue-induced or neurologic condition is very likely. And then we have the structural injury, the little hole, some fiber that rupture, and ultrasound is very good in this lesion. Most of the time we saw these lesions are old, but they tell us that the patient was moving or having some problem, and it can help us to define which muscle we need to train to avoid recurrence of the disease. We decide a local treatment for our patient. She was immediately better. I admit I put a little bit of a local anesthesia surrounding this area, and she was like the happiest dog in the world. And after 1 week, she was doing so well that basically she didn't do other more diagnostic, but only went for treatment. 2 months later, the muscle was so much better, nearly healed. Consider that a muscle and a tendon heal completely in 1 year. This is my last patient. She is lovely. She's the big dog. She was considering that she could run as much as the whippet, but jumping, she had a trauma. The owner was lucky because he was filming, and immediately after this trauma, she started to be lame. She went to orthopedic surgeon. Nothing was found. There were given non-steroid anti-inflammatory drug. They were not working. They did 2 months later radiograph. It was absolutely normal. These were the radiograph of Marta when she was 8 months of age. Nothing was found. We were checking carefully for sign of potential trauma, not the best hip in the world, but no changes so severe that could explain why on the right side there was this persistent lameness. Look at the muscle tone. There is a big muscle on the left side, and the muscle are much less developed on the right side. And at a certain point, she developed a depression in the dorsal aspect of the gluteal region. There was like a hole. And for that reason, and look how thin is the right limb compared to the left limb. And due to that, I went on a neurologist. They were thinking of neurological problem, and they did perform MRI. This is a short abstract of the MRI. While for being such a young dog, there is a little bit of protrusion of the disc between L7 and S1 with narrowing of the space of the nerve. This is the nerve, and the white part is fluid and fat. That is a little bit compressed, but the nerve are nice and fine. So the changes is worrisome because she's like 1 year now, but they are not enough to explain why this dog has such problem. And this is when it came for an ultrasound to understand what was happening. This is another view, and you can see that even if there is narrowing of the passage of the nerve are not compressed. So the changes are not really explaining why she is having this problem. So we saw Marta 6 months later that she started to be lame. She's the sweetest dog ever. And even if MRI was absolutely negative, there was definitely a difference in between the gluten area. we shaped to check the gluteal muscle, and we found the hole that you could feel. It was like a insect bite or a injection, a little bit of the scarring, but basically what we could feel was only a severe reduction of the muscle trophy in this patient. Look, the difference is impressive how the left side compared to the right side is. And she was really lame, especially in the morning, when every time she was getting up, she was severely lame, getting better with exercise. This is quite common in patients that have a tendinous disease. Very, very common. We did perform ultrasound of the hind limb. We do have the muscle of the cranial aspect of the thigh. This line here, this hyperechoic line, this is the fascia between the sartorius and the quadricep muscle, this one, the fascia. This is a critical point for pain. A lot of patients that has problem in putting too much stress in the muscle, get thickening of this fascia. And if you just touch during your physical examination, the difference between the sartorius and the rectus femoris, and they are a little bit sensitive, is incredible how you touch gently and they react due to pain in this area. This is a very important spot. Well, we just saw difference in the left when we have a lot of muscle tone, and on the right where we have severe atrophy. Look at the difference in the same muscle. And then we went in the caudal aspect of the thigh. Again, we have different muscle. I'm not going to tell you how I call the flexor digitorum superficialis, because to me has a particular shape, but look how nicely defined is the left side, that is the side that is not affected. And look instead how look like the right side. I'm not able to really nicely define the muscle, but have hyperechoic region really ill-defined, that is scattering artifacts. So I have a huge inflammation in some of the muscle. This part here is the flexor superficialis. I know that this dog has a severe inflammation in the flexor superficialis, so severe that it stays so for 6 months, and the dog is still lame after trauma. And it's quite impressive to see the difference. What is difficult is in learn, the muscle anatomy, because we need cross-section anatomy. Instead, in the book, we have longitudinal section. But once that you learn anatomy, then it's quite easy to spot where is the problem. This is the longitudinal view. I'm looking at the insertion muscle of the gastrocnemius. That is another very important muscle. This is the fibella. This is the tendinous portion, and this is the muscular portion. This is another side that you really need to be careful when you perform your physical examination, because a lot of patients, for example, that do have TPLO and they still are lame, most of the time are putting too much weight in the insertion of the gastrocnemius, particularly the lateral side, and they're still lame despite a very good and well performed surgical planning. This is the other side. And we do see that, again, we do see scattering artifact that is extending to the insertion and is longitudinally spread in the muscle. This most likely is a longitudinal rupture of the muscle. If we compare the normal anatomy, this is the normal type. You see the shadow of the radiograph. We take out the radiograph to see the shadow of the bone, how I should have my muscle, and look at the affected side, take out the bone, and you see this large area, of the flexor superficialis that is severely affected. Well, sorry. This is the comparison between the normal and the abnormal. Now we know why this patient is so affected, and is so affected because there is a chronic rupture of this muscle. The problem is that every time the dog stands, put a lot of pressure in this muscle, and it's likely that she keep rupturing and rupture again this muscle. And after 6 months, she's still lame. Well, this was quite a challenging patient because now we know why she's lame, but what we should do? Well, this is a tough job for a rehabilitation people. She started physiotherapy and they try to put, I think they use terminal cell to try to stop the recurrence. They put some tutor in her, and I saw this patient few months later. She still has a little bit of atrophy in the right side, but she was no lame, really active. And she was, apart from the atrophy, absolutely perfect. And this was the comparison between the normal and the abnormal. Still not a total normal muscle. This area, you see that is hyperechoic, there is no scattering artifact. This is quite well defined. This is probably a little bit of atrophy and a little bit of fibrosis where before the rupture was, but is healing quite well. And the physiotherapist is taking care that this part doesn't get a fibrosis. And hopefully she will stay no lame and with no problem and no pain. We are not sure if the volume of the muscle will go back to normal, but she's doing absolutely fine, and it's only 3 months after physiotherapy and treatment. And we are very lucky and we are very happy because she's doing so well. Acute with scattering artifact, and chronic with more defined muscle, and getting chronic and not, well, and much better defined because there is not a lot of scattering artifact. This is just to let you see how we can see the difference. These were my 3 patients, and I think they are they want to show you how you can use ultrasound to better define the lesion, especially in tendon and in muscle, that can be so difficult to treat in a systemic way, while it's so good to treat locally. But you need to find out which muscle and tendon is affected. And then even if you are not a superb ultrasonographer, but if you learn to find scattering artifact, you can use that to inject locally the pain management and make the life of your patient so much better. Thank you so much for your attention. I'm happy to take any question.
Oh, thank you so much, Doctor. We do have a comment from Randy. This has been a great presentation. Thank you for the images, and the cases were very helpful. I agree. I think it's wonderful. We do have some time for questions. If anybody has any, they can unmute themselves. We're getting a couple more comments. Thank you. Excellent information. We feel like we learned a lot. Yeah. I agree. I think that those of us who don't look at ultrasound, this has been eye-opening to me for sure.
The big problem is, and hopefully is getting, difference, but the big problem is with ultrasound, you can create lesion if you are not strict, because if you angle in a weird way the probe, you can really, you need to be a little bit expert, used to use it. And sometimes it's difficult to find ultrasonographer really expert, because the specialists are specialists in the abdomen, and usually radiologists don't love orthopedic. But most of the time, orthopedic surgeon and physiotherapists are starting to use ultrasound. And once you became quite used to the technique, really is a fantastic tool. And a lot of paper are coming out, a lot of books are coming out, and finally we have the resources to be able to learn, because I know a lot of people want to learn and they don't know how. I'm doing a lot of courses around the world, and the day that the course come out is full and people need to wait years. But finally, a lot of people are now interested and capable of, so it's really becoming available. And it's quite easy to learn, especially if you are working a lot with painful and pain management. The machine is less expensive, and what you need to know to be able to use it is really not too difficult.
Yeah, we have a couple people saying, how do we learn? How do we learn this? So our president-elect, he's on Facebook Live, and he said, I need to ask you to come do a lab during our forum next year in 2024, because that would be wonderful to have a training laboratory so that we could offer a course on this. We'll have to work on that.
Yeah, no problem. Well, for the shoulder, this is my site, and there is a section where you have 7 short movie that explain you how to perform a shoulder ultrasound. It's free for everybody, and I'm building a lot of cases on musculoskeletal ultrasound. There is also other material in radiology and ultrasound for abdomen and thorax and so on. But I'm trying to create a community of veterinarian experts in musculoskeletal, so we can learn and we can do a lot more research and know more what we are doing.
That's wonderful. I will share that on our Facebook page, and also make sure that everybody's aware of your website. That's wonderful for you.
You know, it's starting. It's still not ready yet, but the shoulder is there at least.
That's wonderful. Well, we all appreciate the time that you've taken with us this evening and out of your busy day, and everybody, thank you for listening. This recording will be available on the website, and also it will be recorded on our Facebook page as well. And thank you so much for working with us today and teaching us about this, Dr. Spattini.
Well, thank you, because actually pain management is one of the reason why I'm so interested in this topic. I'm under pain management, and it really changed my life, and I want my patient have the same luxury. And I must admit that now what you can do for our patient is so incredible. 10 years ago, a severely arthritic patient has a poor quality of life. Nowadays, it can be like a puppy. It's fantastic. I really appreciate working with different expertise, because I'm learning so much from my specialist in pain management that is like mutual beneficial.
Yeah, collaborative medicine, it's a great thing, and I think it's wonderful that we've come leaps and bounds, certainly.
Absolutely.
Well, thank you, everyone. It looks like that this is the end of our hour already, almost. And if anybody else has any other questions, or you think of anything that you would like to ask, just send it to IVAPM and we'll forward it to Giliola for answering. And then you also have her website there, diagnosticmindset.com. Thank you.
Thank you. It was my pleasure.
All right. Bye-bye, everyone.
Bye.